Good day, listener. Welcome to NSG 325, Medical Surgical Nursing 2, Study Session 1, Renal and Urology Nursing. Introduction. Renal and urinary function is essential to life. According to Johnson 2012, bones can break, muscles can atrophy, glands can loof, and even the brain can go to sleep without immediate danger to survival. But should the kidney fail, neither the bones, muscles, gland, or brain could carry on. This statement underscores the critical nature of kidney to survival and the fact that the kidneys are the principal organs of the urinary system. Patients with disorders of the kidneys or lower urinary tract often exhibit similar symptoms regardless of the underlying disorder. The aim of the course is to provide students with an understanding of the structure and function of the renal system. Nursing assessment and management of problems associated with the urinary system, including the kidneys, will be the focus. Other conditions will include the characteristics, risk, factors, and quality of life issues of patients with urological problems. The role of the nurse in preventing and promoting health will be emphasized. Learning outcomes. At the end of this study session, you shall be able to 1. Explain the structures of the urinary system. 2. Highlight the functions of each organ. 3. Use the functional health patterns to obtain a nursing health history. 4. Describe the correct techniques for physical examination of the urinary system. 5. Explain diagnostic test. Structure and assessment of the urinary system. The urinary system is composed of the kidneys, ureters, bladder, and urethra. A thorough understanding of the urinary system and renal physiology is necessary, both to assess and to plan and implement appropriate nursing care for healthy patients and those with renal or urinary dysfunction. The system performs excretory, regulatory, and secretory functions, and the structures of which precisely maintain the internal chemical environment in the body. Structure of the kidneys. There are two kidneys located behind and outside the peritoneal cavity, retroperitoneal, on the posterior wall of the abdomen from the level of 12th thoracic vertebra to the 3rd lumbar vertebra. The weight of the kidney in an adult is between 120 and 170 grams and measures 12 centimeters, above 4.5 inches long, 6 centimeters, and 2.5 centimeters thick. The kidneys are well protected by the ribs, muscles, fascia, peritoneal fat, and renal capsule, which surround each kidney. It should be noted that the right kidney is lower than the left kidney. This is because of the space occupied by the liver. The kidney is surrounded by a considerable amount of fat and covered by a fibrous capsule, which protects the kidney and serves as a shock absorber. On the medial surface of each kidney is a depression called the hilus. This serves as an entry point for nerves, blood vessels, and the ureters enter the kidney. The hilum gives the kidney its typical bean shape. The internal structure of the kidney. The kidney consists of two major sections, the outer cortex and medulla. The cortex. This is the outer portion of the kidney, containing the glomeruli, proximal and distant tubules, and cortical collecting ducts, and the adjacent vertebral capillaries. Part of the loop of hair is embedded in the cortex. The medulla. The medulla resembles pyramids because of the long loops of hair and the medullary collecting ducts and their corresponding capillaries, known as vasa recta. The apices, tops of the pyramids, are called papillae. Urine passes through these papillae into the calyces. The minor calyces merge to form the major calyces, which in turn merge to form the renal pelvis. Urine from the renal pelvis is drained through the ureters to the bladder. The nephron. This is a functional unit of the kidney. There are about 1 million nephrons in each kidney, each containing the glomerulus formed by the arterioles, Bowman capsule and a tubular system. The tubular system is divided into sections: proximal convoluted tubule, loop of Henle, distant convoluted tubule, and the collecting tubules. It should be noted that the glomerulus, Bowman capsule, proximal convoluted tubule, and the distal tubule are embedded in the cortex, cortical nephron, while the loop of Henle and the collecting tubules make up the medullary nephron. Blood supply. The blood supply is through the renal artery, which is a branch of the abdominal aorta. Approximately 20 to 25% of the cardiac output flows to the kidney. The renal artery divides into smaller branches, forming the afferent arterioles. The afferent arterioles further divide into a network of capillaries known as the glomerulus, a tuft of 50 network of capillaries, which unites to form the efferent arteries, splitting to form capillary network called the peritubular capillaries, which surrounds the tubular system. Ureters, bladder, and urethra. Ureters. The ureter is a long fibromuscular tube that connects each kidney to the bladder. It measures about 25 to 35 cm in length and 0.2 to 0.8 cm in diameter. The ureter transports urine from the renal pelvis to the bladder. At the ureter-pelvic junction, the ureters enter the kidney and passes through the psoas muscle over the brim of the pelvis to enter the bladder at ureter-vesical junction. At the two junctions, the lumen of the ureter is narrowest, and this structure explains why the structure can easily be occluded by calculi, tumors, adhesions, and inflammatory processes. Urine, which is formed within the nephrons, flow into the ureter. The ureters are composed of longitudinal and circular smooth muscle fibers, which control one-way flow of urine and thereby prevent a reflux of urine into the pelvis. Bladder. The urinary bladder is a hollow muscular distensible organ which lies behind the syphilis pubis, anterior to the vagina female and the rectum. However, when the bladder fills, it distends into the abdominal cavity. Its primary function is to serve as a reservoir for urine and to eliminate waste products from the body. In the normal adult, urine output is approximately 1005 mm daily, which varies with food and fluid intake. The triangle formed at the point of entry of the two ureters and the opening of the urethra at the base of the ladder is termed the trigon. The trigon is fixed to the pelvis by ligaments and the shape does not change even when the bladder is filling or emptying. It is attached to the abdominal wall by an umbilical ligament called the urachus. As a result of this attachment, as the bladder fills, it rises towards the umbilicus. The mucosal lining of the bladder is composed of transitional epithelium, also referred to as urothelium. This is unique to the urinary system as it is resistant to absorption of urine. This is why the urinary waste from the kidneys do not leak out but remains in the urinary system. The urethra. The urethra is a small muscular tube that leads from the bladder neck to the external meatus. It serves as a passage for urine during voiding and semen during ejaculation. The structure is composed of the urothelium and cutaneous layers which are continuous with the bladder. Smooth muscle fibers from the neck of the bladder extend into the urethra and are supported by circular smooth muscle fibers. There are specialized C-shaped striated muscle fibers which form the rhabdosphincter or external sphincter. This surrounds a portion of the urethra. Voluntary contraction of the muscles sphincter prevents leaking of urine when bladder pressure increases. In the female, measures about 1 to 2 inches long and lies behind the syphilis pubis, anterior to the vagina. The rhabdosphincter encircles the middle 1/3 of the urethra. The meatus is located 1.0 to 1.5 cm below the clitoris. Proximal to thirds are lined by transitional epithelium, while distal 1/3 of the urethra is lined by stratified squamous epithelium. The short length of the female urethra contributes to the increased incidence of urinary tract infections in women. The male urethra. The male urethra originates at the bladder neck and extends through the length of the penis. It measures about 8 to 10 inches long. It consists of 4 parts: intramural or preprostatic part. This measures 0.5 to 1.5 cm long and extends almost vertically through neck of the bladder. It is surrounded by the internal urethral sphincter. The diameter and length varies depending on whether bladder is filling or emptying. Spongy urethra or penile urethra. This section courses through the corpus spongiosum. The initial widening occurs in the bulb of penis and again widens distally as navicular fossa in the glans penis. It measures approximately 15 cm in length. The spongy urethra terminates at the urinary meatus. Blood supply. In the male, the arterial blood supply is by inferior vesical artery, middle rectal artery, and the internal pudendal artery, and the venous drainage is into prostatic venous plexus. In female, the arterial blood supply is by the internal pudendal and vaginal artery, and the venous drainage by corresponding veins. The nerve supply in the male is derived from the prostatic plexus, while in the female, it arises from the vesical plexus and the pudendal nerves. Functions of the kidney. The main function of the kidney is electrolyte and acid-base balance. Other functions include urine formation, excretion of waste product, control of water balance, control of blood pressure, renal clearance, regulation of red blood cell production, synthesis of vitamin D to active form, secretion of prostaglandins. Functions of ureters, bladder, and urethra. Urine formation by the kidney flows from the renal pelvis through the ureters into the bladder. This movement is enhanced by peristaltic waves from contraction of the smooth muscle in the walls of the urethra. There are no sphincters between the ureters and the bladder, whereas there is a sphincter in the urethra. Storage of urine. The bladder is principally the reservoir for urine. The wave of peristalsis produced by the muscles is unidirectional, thereby preventing a backflow reflux of urine from the bladder. This is also possible because each ureter enters the bladder at an oblique angle. However, when the bladder is over-distended, pressure in the bladder is elevated. This elevated pressure can be transmitted back through the ureters, leading to ureteral distension and possible reflux or backup of urine in the kidney. A condition known as pyelonephritis, kidney infection, can ensure. In addition, kidney damage from the elevated pressure causing hydronephrosis may result. Voiding. Controlled voiding is influenced by muscle and nerves. Voluntary control is a learned behavior and not present at birth. Age-related changes in the urinary system. At this point, we will discuss the changes that take place in the structures of the urinary system as a result of aging process. Kidneys. During the process of aging, between the 3rd and 9th decade of life, there is 20 to 30% reduction in size and weight of the kidneys. Other changes include clinical implications. The age-related changes are associated with the following clinical situation: reduced renal functional reserve, risk of renal complications in illness, risk of nephrotoxic injury, and adverse reactions from drugs, potential for falls, risk of volume overload in heart failure, dehydration, hypernatremia with thiazide diuretics, hypernatremia associated with fever, hyperkalemia with potassium-sparing diuretics, reduced excretion of acid load, increased risk of urinary urgency, incontinence, urinary tract infection, nocturnal polyuria. Nursing assessment of the urinary system. Collecting data about previous health problems or diseases provides useful information to the healthcare team when evaluating the patient's current renal or urologic problem. A comprehensive health history to elicit information on risk factors is the first step in assessing a patient with urologic dysfunction. A variety of diseases or clinical situations can place a patient at increased risk for developing renal or urologic problems. In this lecture, the functional health pattern will be used to obtain nursing history. Excellent communication skills are required because many patients are embarrassed about or uncomfortable discussing genital urinary functions or symptoms. The nurse must be sensitive to use of language and choice of words which the patient can readily understand. Nutritional metabolic pattern. The quality of fluid intake in 24 hours should be noted because inadequate fluid may be associated with urinary tract infection, calculi formation, and even renal failure. Caffeine, carbonated beverages, or spicy foods aggravate urinary inflammation. Herbal teas may cause diuresis. Unexplained weight gain may be associated with fluid retention secondary to renal problems. Elimination pattern. Urinary elimination pattern, such as daytime or nocturnal voiding. The frequency should be noted. Experiences of urinary frequency, urgency, and incontinence, bothersome lower tract urinary symptoms. The nurse should inquire about changes in urine color at beginning, throughout, or end of urination. The nurse should also note that constipation and fecal impaction may obstruct the urethra, resulting in incomplete bladder emptying and urinary overflow. Information regarding the use of assistive devices such as catheter or collective device should be noted. Vasovar maneuver, straining, Crate's method, pressing lower abdomen, stretching the rectum to empty bladder to empty urine should also be explored. Activity exercise pattern. Explore patient's level of activity. Sedentary lifestyles may result in urinary stasis, physical immobility, resulting demineralization of bones and increased calcium precipitation. Explore for weak pelvic floor muscles, post-pelvic surgery, which may be responsible for urinary leakage with activities. Explore for experience of prostatitis or epididymitis after long-distance driving or lifting heavy loads. Sleep-rest pattern. LUTS may result in sleep deprivation, daytime sleepiness, fatigue. Nocturnal may be related to polyuria and poorly controlled diabetes mellitus, alcoholism, or excessive fluid intake. Cognitive perceptual pattern. Visual acuity, alertness, ability to understand instructions, assess a patient for pain, such as dysuria, groin pain, costovertebral pain, suprapubic pain, explore the location, character, duration, and so on. Pain is a frequent symptom of urinary tract problems and may be investigated. Self-perception, self-concept pattern. Patients experience lower urinary symptoms such as incontinence. Retention may experience loss of self-esteem. A feeling of fatigue may also occur. Role relation pattern. Effects of urinary problems on relationships and work. Poor health and negative body image can affect roles. Sexuality, reproductive pattern. Effects of urologic problems on sexual satisfaction and intimate relationships should be explored. Problems associated with personal hygiene and fatigue may affect sexual relationships, which may be an indication for counseling of both partners. Physical examination of the urinary system. Because renal dysfunction affects all body systems, a head-to-toe assessment is indicated, with emphasis on the urinary tract specifically. The techniques of inspection, palpation, percussion, and auscultation are followed. Let us begin with inspection. Inspection. This involves using the sense of sight. Examine the patient's skin for pallor, yellow-gray cast on the skin, excoriations, changes in skin turgor, bruises, texture, for example, rough or dry skin, mouth stomatitis, ammonia breath. Inspect the face and extremities for generalized and peripheral edema, bladder distension, masses, and enlarged kidney. Examine the abdomen for midline mass in the lower abdomen may indicate urinary retention or unilateral mass. Check client's weight. Weight gain secondary to edema, weight loss and muscle wasting in renal failure. Edema may be observed, particularly in the face and dependent parts of the body, such as the feet and sacral areas, and is suggestive of fluid retention. An increase in body weight often accompanies edema. A 1 kg weight gain equals 1000 mm of fluid gain. Palpation. The costovertebral angle (CVA) is a useful landmark to palpate the kidneys. This is the angle formed by the rib cage and the vertebral column. Direct palpation may help determine the size and mobility of the kidneys. It may be possible to feel the smooth, rounded lower pole of the kidney between the hands. The right kidney is felt more easily than the left kidney because it is lower than the left one. Palpate for CVA tenderness, non-palpable kidney, and palpable masses. Enlargement of the kidney may suggest the presence of tumors. Percussion of the costovertebral angle for kidney tenderness. Diagnostic test. The following diagnostic tests are required to confirm diagnosis of renal and urinary problems. Urinalysis. A clean carved specimen of the first AM urine is helpful for the following tests. Specify gravity. Kidney's ability to concentrate urine. This may be measured using a multiple task dipstick. An urinometer is also used even though it provides the least accurate result. Urine culture and sensitivity for presence of microorganisms and to determine the specific treatment regimen. Creatinine clearance test. This is the most accurate measure of renal function. This is because all creatinine in the blood is excreted by the kidney. Procedure. Obtain a blood sample and a timed urine specimen. Blood is drawn at the start of the test and the AM of the day that the 24-hour urine specimen collection is complete. Maintain the urine specimen on ice or refrigerate. Encourage adequate fluids before and during the test. Vanillin Mandelic acid test (VMA). This is used to diagnose tumor of the adrenal gland, pheochromocytoma. The test identifies an assay of urinary catecholamines in the urine. What the nurses should do before the test. Instruct the client to avoid foods such as caffeine, cocoa, cheese, gelatin at least 2 days prior to beginning of the collection and during collection. Kidney, ureters, bladder, radiograph, KUB. An X-ray film that views the urinary system and adjacent structures to detect urinary calculi. Bladder ultrasonography, a non-invasive method of measuring the volume of urine in the bladder. Intravenous parallelogram, IVP, the injection of a radiopaque dye that outlines the renal system, position, size, shape of kidneys. Renal angiography, the injection of a radiopaque dye through a catheter for examination of the renal arterial supply. Assess the client for allergies to iodine, seafood, and radiopaque dyes. Inform about possible burning feeling of heat along the vessel when the dye is injected. Computed tomography and magnetic resonance imaging provide cross-sectional views of the kidney and urinary tract. Renal scan. This requires injection of an intravenous radiopaque substance for visual imaging of renal blood flow. Before the procedure, instructs the client that imaging may be repeated at various intervals before the test is complete. Assess for signs of delayed allergic reactions such as itching and hives. Cystometrogram (CMG). The test evaluates bladder and detrusor muscles tone to record the pressures exerted at varying phases of the bladder. Cystoscopy. To examine bladder mucosa for inflammation, calculi or tumors using a cystoscope, and biopsy may be obtained. The nurse should instruct the client that MPO status should be maintained after MN before the test. After the test, the nurse should monitor for postural hypotension. Note that a pink-tinged or tea-colored urine is common. Monitor for bright red blood or clots. Renal biopsy. Insertion of a needle into the kidney to obtain a sample of tissue for exam. MPO after midnight. Provide pressure to the biopsy site for 30 minutes. Check site for bleeding. Force fluid to 1,500 to 2,000 mm. Instruct to avoid heavy lifting and strenuous activity for 2 weeks.